Just a minute. Our IT people are working on something. Okay. Good afternoon and welcome to all of you in this Asthi's webinar series. Today we are really privileged to have one young investigator as our speaker, and we very much want more and more young investigators to give their presentation and share their exciting and stimulating work with us. Today we have Dr. Kripa Elizabeth Cherian from Christian Medical College, Vellore, from the Department of Endocrinology. Kripa is currently an associate professor, and Kripa is a clinician. She has done her MD followed by DM and DNB endocrinology, and her area of research interest is primarily metabolic bone disease, although she works also in transplant endocrinology. Kripa has, at this young career, she already have 84 papers in national and international journals. And Kripa is also associated with editorial work with Indian Journal of Endocrinology and Metabolism. Today, Kripa will speak on her recent work related to the effect of teriparatide on BMD, trabecular bone score, and hip structural analysis. With this brief introduction, let me welcome Kripa and request her to give the presentation. Kripa?
Thank you, sir, for your very kind words of introduction. It's a privilege for me to be on the ASTI webinar series. Once again, I thank the organizers for having me here. So today I'd like to speak on teriparatide therapy in postmenopausal osteoporosis and what is its impact on the BMD, the trabecular bone score, and measures of hip structural analysis. So before I go into the study, I'd like to lay the foundation of something about the treatment of osteoporosis and also the basics of BMD, TBS, and HSA. So we know that as far as bone strength is concerned, it is not bone mineral density alone that plays a role. There are other structural properties of the bone like the trabecular architecture of the lumbar spine and the hip geometry that are responsible for further conferring bone strength. And there is this constant bone turnover of bone formation and bone resorption that keep repeating in cycles. So it is an interplay of these factors that actually determine how strong a bone is or how prone it is for fracture. So we know that as children grow up, by the time they reach their third decade, that is between 20 to 39 years of age, they achieve what is known as the peak bone mass, after which there is a slow but a steady decline in the bone mass. And women also have this additional event known as menopause, in which there is a precipitous decline in the levels of estrogen, which leads to a rather abrupt decline in bone mineral density, in addition to the age-related decline. So this increased porosity or decrease in bone mineral density is what we refer to as osteoporosis, and if left untreated, this can cause fragility fractures. Now, that is why it is so important to preemptively screen for osteoporosis, and this screening is done using a DEXA scan. DEXA stands for dual energy X-ray absorptiometry, Here, the 3D structure of the bone is projected as a 2D image, and the bone mineral content per unit area is what the DEXA scan interprets as the bone mineral density. This is actually the aerial bone mineral density. So what is the principle of the DEXA? So from the name, there are two energy beams. Usually this is about 70 kV and 40 kV. These pass through the body, and these two different energy beams are attenuated to different extents by various tissues present in the body, like the bone, the fat, and the muscle. So this difference in attenuation is compared amongst the tissues, and that is how the DEXA is able to differentiate between the content of fat, muscle, and of bone, and this is what we exploit in measuring the bone mineral density. Now once we have the bone mineral density, we derive what is known as the T scores and the Z scores. What are T scores? These scores are important to know because the definition of osteoporosis and low bone mass is dependent on these scores. So in the T score, we compare the bone mineral density of the patient with that of a young individual who is in his third decade, where he attains his peak bone mass. And this is what gives the T score, which is used in postmenopausal women and men who are 50 years and more. And any T score that is minus 2.5 and less defines osteoporosis. Anything that is minus 1 and more is normal, and anything between the two is osteopenia. On the other hand, Z score does not compare with a young adult, but it compares the BMD to the BMD of an age and gender matched individual, and it is used in premenopausal women and men who are less than 50 years. And any Z score that is minus 2 and less is used to define a low bone mass. The common sites where we measure the BMD are the femoral neck, the lumbar spine, and the distal third of forearm. So DEXA scan or BMD assessment is indicated in postmenopausal women who are at least 5 years after menopause, according to the Indian Menopause Society. If they have other clinical risk factors, they need to be screened earlier, and men also need to be screened above 70 years of age. Now let's come to what the trabecular bone score is. Now this is a unitless measurement, unlike the bone mineral density, which is expressed as grams per centimeter squared. So to put it in very simple words, trabecular bone score is something that is done by the DEXA scan. It assesses the trabecular how the trabeculae are disposed within the lumbar spine, and this is done by measuring the pixel variations between the different trabeculae. Higher the TBS, the better is the trabecular microarchitecture, and lower the TBS, it indicates a more porous trabecular structure and poorer the quality of the bone. So this is how a TBS looks like what is given by the DEXA image, and anything that is more than 1.35 is normal. Anything that is less than 1.35 indicates that there is some qualitative deterioration of the bone. Now let's come to the third aspect, hip structural analysis. Again, there are many factors that determine the strength of the bone in addition to bone mineral density. For example, the force, what is the rate, the magnitude, and the direction of application of the force. And there are certain geometric aspects of the hip that are also important in determining bone strength. Before I go into the next slide, I'd like to take you through various forces that can be applied on the femur. For example, this denotes a compression force. This is a tension force. I can bend the bone or shear the bone or apply a torsional force. So all these forces are also important in the context of bone strength. Now this hip structural analysis also can be done on the DEXA machine. Usually when we do the BMD assessment, the DEXA takes images of the proximal hip, and the hip structural analysis can be extrapolated from these images. Now this is analogous to certain engineering models. For example, engineers construct these huge buildings. We don't know how strong or sturdy they are, so they use computer simulated models to assess how much load a building can take. Now, when we talk of the hip structural analysis, this primarily has to do with the proximal part of the femur, and there are three regions that are of interest to us. One is this plane of the narrow neck, which is the narrowest portion of the femoral neck. The second is this plane, which is the femoral shaft, which is 2 centimeters below the lesser trochanter. And the third plane is the intertrochanteric plane. Now, this is the neck shaft angle, and this intertrochanteric plane is a plane that bisects this angle. There are also certain assumptions that we make when we assess the HSA. These assumptions are that in the femoral shaft, there is only cortical bone, whereas in the narrow neck, 60% is cortical bone, and in the intertrochanteric region, 70% is cortical bone, the rest is trabecular. Some of the measurements that we do in the hip structural analysis include the hip axis length, the femoral neck length, and the neck shaft angle, the normal range of which is between 126 and 135. Anything less or anything more than this range again can predispose a person to fracture. Now let's see what all do we assess using the hip structural analysis. This involves some complicated physics, but I'll try to explain as simple as possible. CSA stands for cross-sectional area. This is actually indicative of how strong, how well a bone can withstand axial forces. So higher the cross-sectional area, the better the resistance of the bone to an axial force. Cross-sectional moment of inertia and section modulus, these do not have to do with axial forces but with bending forces. And to put it in very simple words, how strong a bone can resist a bending force. That is what is given by cross-sectional moment of inertia and section modulus. How they differ is that cross-sectional moment of inertia indicates what is the maximum bending force that a bone can take before it distorts. That is what is cross-sectional moment of inertia, whereas section modulus is there is a subtle difference. When you bend a bone, how much resistance the bone offers to bending, that is the section modulus. Now, all these first three parameters, higher the value, the better or the stronger the bone is. Whereas for buckling ratio, higher the value, more vulnerable the bone is to a fracture. I'll come to buckling ratio. So buckling ratio is something that indicates cortical stability. And how do we measure that? So imagine this is the cross section of the bone. This is the radius of the bone, or half of the periosteal width, and this is the cortical thickness. So it is this D0 by T that indicates the buckling ratio. And anything that is more than 10 at the region of the narrow neck indicates a high risk for fracture. Now with age, what happens is there is progressive cortical thinning, which means that there is a progressive increase in buckling ratio and an increase in the fracture risk. I'll also take you through a series of buckling ratio in different decades of life. I just want you to concentrate on this column over here, which is buckling ratio at the narrow neck. This is around 6 at 20, 8 at 34, 7.6, 41, 10.5, 59, around 10 again 72, 13 at 84, 17 at 93 years of age. So it progressively increases as the age advances. And before I go into the study, I'll just also take you through a case of a 59-year-old postmenopausal lady known to have diabetes that was poorly controlled. She was referred from orthopedics for the management of her diabetes. She had gone to ortho because she sustained a right hip fracture. So after we took care of her diabetes, we got her bone health assessment. So can you see this T-score at the lumbar spine, which is minus 1.2, and at the neck it is minus 2.2. So these are well above the cutoff that is used to define osteoporosis, and that is what her BMD showed. So let's just look at her TBS of the same patient. The lumbar spine BMD was in the osteopenic or the non-osteoporotic range, but look at her TBS, which this is well below the cutoff of 1.2, which indicates very much degraded microarchitecture. And that is why TBS conveys additional information besides BMD in bone health assessment. Let's also look at the buckling ratio. She had come with a fracture of her hip. The neck T-score is not osteoporotic, but look at the buckling ratio at the narrow neck, which is more than 10. And that is the importance of these other measures like TBS and HSA in the context of bone health assessment. So to introduce our study, we know that menopause is an important milestone in the life of an individual, of a woman, where she transitions from the reproductive to the non-reproductive phase. And this transition brings with it osteoporosis, which, if left untreated, can predispose to fractures. And the 1-year mortality after a hip fracture was shown to be 20% from our center. So, various studies that were undertaken at our center have shown the prevalence of osteoporosis to be as high as 50%, of asymptomatic vertebral fractures to be as high as 35%. And added to this is the problem that most of the postmenopausal women are not aware of the fact that they need to be screened, and sadly many primary care physicians also showed suboptimal knowledge, and thus osteoporosis continues to be a burden that is grossly under-recognized and under-treated. So now when we talk about the treatment of osteoporosis, we have a whole lot of agents available, like those that inhibit resorption, the anabolic agents, and a relatively recent agent, romosozumab, that has both anabolic and anti-resorptive properties. So from this entire therapeutic armamentarium, what do we choose? Various agents have shown about 35 to 50% risk reduction in the occurrence of vertebral fractures, and these are the various targets on which these available agents act. Our area of interest today lies in PTH, parathyroid hormone, which is known to be an anabolic agent when it is given intermittently. It promotes the differentiation of mesenchymal stem cells to pre-osteoblasts and osteoblasts, and also downregulates or inhibits certain inhibitors of the bone formation pathway. So the concept with anabolic therapy is that we know that bone is a dynamic tissue which goes through phases of bone formation and bone resorption. And this bone formation and bone resorption is always coupled. So when we give anabolic therapy, there is an increase in bone formation. Gradually, there is also an increase in bone resorption. So when there is bone formation and before bone resorption has set in, that gap is known as the anabolic window, and that is what we try to maximize when we give an anabolic therapy. So various studies, this was one landmark trial, the fracture prevention trial, which studied the effect of teriparatide on about 1600 postmenopausal women, where it was administered for 2 years, and it was shown that there was a significant reduction in both vertebral fractures and non-vertebral fractures as compared to placebo. Similar to teriparatide, there is abaloparatide, which is an analog of parathyroid hormone related peptide. And this agent again showed a dose dependent. Various doses were used of 20, 40, and 80. There was a placebo group and teriparatide group. There was a dose dependent increase in BMD at the lumbar spine, femoral neck, and the total hip. And these increments were also shown to be more marked than even teriparatide. The newer agent romosozumab has been utilized as well in osteoporosis and in those at high risk for fractures. Here again, it was shown that there was significant increments in the BMD as well as reduction in the occurrence of new fractures. So again, the another point that I want to make is that bisphosphonates have a prolonged skeletal retention time, but the other agents have a shorter duration of action. So all other agents such as parathyroid hormone or denosumab or romosozumab, all of them need to be transitioned to eventually to a bisphosphonate. And based on these, there are various modalities of treatment, combining both and sequentially administering both. So what is the need for our present study? In the Indian context, there is paucity of data on the effect of teriparatide on bone mineral density, the trabecular bone score, hip structural analysis, and vertebral fractures. So we aimed to study the impact of teriparatide on bone health in postmenopausal women with osteoporosis, and our specific objectives were to study the effect of teriparatide on BMD, on new fractures, TBS, HSA, bone biochemistry, and the bone turnover markers. So this was a prospective study in which the recruited women were treated for 2 years with teriparatide. Bone parameters were assessed both before and after therapy. We included ambulant postmenopausal women 50 years and above with severe osteoporosis and or vertebral fractures who were willing for daily injections, excluding those who were already on treatment for osteoporosis, those who were in advanced stages of chronic kidney disease, anyone who had a secondary osteoporosis, an underlying malignancy, or a secondary hyperparathyroidism were excluded. So of the 121 who were screened, 72 were excluded based on our exclusion criteria, and of the remaining 49, 43 completed the 2 years of study. Our assessment consisted of clinical examination, assessment of the bone mineral parameters, the bone turnover markers that included the CTX and the P1NP, and the DEXA parameters, whatever I mentioned, BMD, vertebral fractures, TBS, and the HSA. So I mentioned the categorization of BMD as well as TBS. Vertebral fractures can also be assessed by the DEXA scanner. This is analogous to a lateral X-ray of the spine of poor resolution. We compare the height of the vertebra. So anything that is less than 25% height loss is a mild fracture, 25 to 40% is a moderate fracture, and anything that is more than 40% is a severe fracture. Now, mild fractures that are reported by the DEXA scan were excluded. The reason being that they could also be some normal anatomical variants. So, only moderate and severe fractures were included in this present study. Our primary outcome was to study the occurrence of incident or worsening of vertebral fractures. The secondary outcomes were to study the changes in the following parameters after teriparatide: BMD, trabecular bone score, and various measures of the proximal hip geometry. All women recruited received teriparatide for 2 years along with supplemental calcium of 1 gram per day and cholecalciferol of 1000 to 2000 international units per day. All who were vitamin D deficient were treated with vitamin D and made replete before initiating teriparatide. Appropriate statistical tests were used in this analysis. Now, coming to the baseline characteristics, the mean age of the 43 women was about 65 years. The mean BMI was 22.7 kg per meter squared. They were vitamin D replete, as I mentioned. And it is interesting to note that as these women were followed up, there was no significant change in their height on follow-up. And why is this important? If there are new vertebral fractures or worsening of an existing vertebral fracture, women tend to lose height. And as you can see, there has not been a significant change or decrement in height, which is important. Coming to the bone biochemistry, they were not significantly different over the 2 years of the study period. When we looked at the lumbar spine BMD, there was a significant increase over 2 years. Similar increase was noted in the BMD at the femoral neck. The trabecular bone score, which again indicates qualitative aspects of the bone, showed a significant improvement at the end of 2 years from 1.16 to 1.271. Vertebral fractures at baseline were present in 32 of the 43 subjects. After initiating teriparatide, new fractures were seen to occur only in 3 subjects on follow-up. Bone turnover markers, both the bone formation marker and the bone resorption marker significantly increased, and this is expected with anabolic therapy. Let's come to the hip structural analysis. So these are 3 parameters which I said, if they are high, it is good for the bone, and all these parameters definitely increased with treatment. They were significant, and this was in the region of the intertrochanteric plane. Similarly, at the femoral shaft, there were significant improvements in the cross-sectional area and the cross-sectional moment of inertia. At the narrow neck, buckling ratio, remember I mentioned, higher the buckling ratio, more is the cortical instability. Buckling ratio with treatment declined, and this decline at the narrow neck was significant. So coming to our discussion points, I had shown one study, fracture prevention trial, which was the landmark teriparatide trial. So in that study, new vertebral fractures were seen in 5% of cases and 14% in the placebo group. In our study, new fractures were seen in about 7%, that is 3 individuals, and all subjects were scheduled for bisphosphonates during follow-up. So the new fractures in our study were comparable to what was demonstrated previously. So some of the strengths of our study are that this was prospective. We assessed vertebral fractures, and this is the first Indian study to assess the effect of teriparatide on all the bone health parameters such as the BMD, trabecular bone score, and the geometric indices of the hip. Of course, we acknowledge that the numbers were small and 6 women were actually lost to follow up in this study. So to conclude, teriparatide does help in reducing the incidence of new fractures while improving the BMD the TBS and the hip geometry significantly. And so osteoporosis is a silent disease that definitely needs to be preemptively screened. There are several agents in the therapeutic armamentarium, and anabolic therapy is indicated in the presence of prevalent fractures and or severe osteoporosis, and significant improvements in parameters of bone health are definitely demonstrable. Thank you.
Okay. Thank you so very much, Kripa, for such a lucid presentation and explaining to the audience all the details of the various measurements of assessment of the lumbar spine and hip you have done. I'm sure it would be of immense use to the young investigators, particularly who are not from the clinical background in this audience. Now, could you go back to your slide on PINP and CTX?
Yes.
Yeah, so this is after 24 months. What
Yes.
I find very interesting here is that
Yes.
if you divide baseline PINP and CTX
Yes.
and versus 24-month PINP CTX,
Yes.
what kind of difference do you get? Because what I find is that the anabolic window after 24 months has actually increased in your case, rather than what is said about teriparatides, the limitation that with time, by 24 months, the anabolic window is lost. But in your case, actually, the anabolic window is not lost. Rather, I can see it appears to have increased or little bit decreased. I mean, here in this
Yeah, so
case,
with
baseline,
time,
yeah,
definitely the bone formation marker increases with teriparatide therapy. Along with that, there is an increase in bone resorption as well. And while at the end of 2 years, beyond 2 years, there is no use of further continuing teriparatide therapy. There are many theories for such postulates, one being that there might be the development of antibodies, the second being that with continued therapy there is a down regulation of receptors and therefore reduced sensitivity. So whatever gains in BMD are demonstrable, after teriparatide therapy its effect wears off and it needs to be reinforced with an anti-resorptive, which can either
that is
be.
not my point. Yeah, I understand. That is not my point. Actually, in the at the baseline, rather,
Yes.
suppose what would be your PINP and CTX level 3 months after teriparatide
Okay.
initiation. So at that time point, most probably your PINP level would be much higher compared to CTX1, and then if you want to calculate the real anabolic window, so you have to
Yes.
do it somewhere around 3 months post PTH initiation, and that versus 24 month, so that you
Yes.
can, because at 24 month I clearly see that you still have the ratio is somewhere around 5.5. With that
Mm-hmm.
ratio, PINP to CTX ratio, if the recommendation is that no, that ratio is not enough to give you continued BMD support, that means at 3 months, I am interested to see in your South Indian study population, what would be the PINP to CTX ratio at 3 months post initiation. What you said about the mechanism of why the anabolic window is lost is actually the rankle. The rankle gets severely stimulated by PTH, and that rankle stimulation, the effect gradually adds up to hyperactivate the osteoclast, and that essentially overcomes the osteoblastic formation. So osteoblast fails to keep up with the resorption post 18 months because of the rankle effect that sets in due to the PTH effect on osteoclast via the rankle, right? But yeah, I would be interested to know, or if you have the data at 3 months or something at an earliest time point post teriparatide initiation, what would be your PINP and CTX data?
I don't think we have looked at it that early. Probably at 6 months we might have data.
Yeah.
Probably we'll go back and look into that and look at the ratios.
Right. Well, I'll stop here. Let others ask this question, please. Anybody else having question? Yes, please, Dr. Vaidya.
Yeah. Congratulations, Dr. Kripa. It was a nice talk. And
Thank you.
The question that Dr. Naibedya asked, a similar one, how often at other intervals you have done these markers? At what intervals?
Yeah, so usually on teriparatide therapy, it is not generally recommended to monitor the bone turnover markers during the study period, but we have done it every 6 months.
Oh, so you have another 2 more readings are there.
Which I have not put in this, but probably the original data set would have it. But on teriparatide therapy guidelines generally do not recommend that the bone turnover markers be monitored, but that to continue teriparatide for a total duration of 2 years.
So from your memory, do you find that there is any, out of your 40 and odd number of cases, were there marked variations at different time cuts?
There was a progressive increase. I didn't get your question, ma'am, that last one.
Yeah, what I'm saying is that you had 40 and odd number of patients in this
43,
trial.
yes.
And were there marked differences at different time cuts? Were there marked differences?
So all of them did show an increment, but between subjects, yes, the variation is definitely high. It is a test that is highly variable.
Okay, and so do you recommend that in between you would add any other therapy additionally to PTH?
Yeah, so there have been some sporadic, not in this study, but sporadic case reports, cases where we have actually, I remember the case of a young lady who presented with very severe osteoporosis, who was actually losing BMD even while on teriparatide. So we had to continue, while continuing teriparatide, we had to intermittently give her denosumab as well every 6 months, with which her BMD has remained stable so far. So likewise, there are occasional cases in which we've had to give a combination therapy with teriparatide.
Right, so how often do you do BMD? At what intervals BMD has been done?
Yearly?
No, that's a baseline. But in between, as you say that 6 monthly you've done the markers.
The bone turnover markers, BMD is, we tend to do it every year, because these are individuals who have come with severe osteoporosis with or without vertebral fractures. So we do it as frequently as 1 year.
Okay, thank you. And as you very well know, CDRI has phytomolecules for the treatment of osteoporosis. and
Yes.
has also undergone a clinical trial. Would you be
Yes, ma'am.
interested, or would you like to? Have you looked at it?
We
Yeah.
haven't looked at it, but probably we will. I will get back to my professor also, who is on the who is in the meeting, and probably we will get back to you on that.
Yeah, so I'll ask Dr. Naivedya, besides our institute, where else we have clinical data on DCISU?
Clinical data, other than no, there is so far not that I am aware of in terms of published literature. So I hope that the US company to whom we have licensed it will begin the trial soon in the postmenopausal women in US, and that is what our hope is, to get that data.
Okay,
Right?
thank you.
Yes, Dr. Paul, your
Yeah, I
comments,
think we'll
opinions,
be
please.
interested. Thank you so much for the opportunity Dr. Kripa presented. And like in addition to Dr. Vaidya had asked, actually we find two set of patients when we do bone turnover marker at the end of 6 months. One group, the resorption takes over so much, then we have to add anti-resorptive agent in addition to teriparatide. There is another group follows a set pattern, and you had asked question how long it lasted. About this, this is still anabolic window. Yes, we have found. I don't know. This data is very selective patients, severe osteoporosis, rural women. So they may not be the prototype of urban Tamil Nadu, urban Vellore. They are not the prototype. We have taken only the severe ones. So whether moderate osteoporosis will behave in the same way, we are not sure. We have also seen this window is maintained even at 24 months. So there was a discussion in our ISBMR last meeting with Dr. Padeda and all the group. In fact, there is a promotion like we can extend teriparatide for more than 2 years. That is 3 years. Of course, we know that the extended study utilizing the anabolic window in that break. Other than that, we are not able to explain why this is persisting. We got it first.
But you know, yeah, sorry. What I'm saying is that this terminology, anabolic window, actually has been popularized by Bilizikian, although this concept has been challenged in recent years. So, but there is no doubt that the rank ligand levels go up very high, and that is the reason teriparatide loses its action. And in this regard, the second generation one, which Kripa has mentioned, abaloparatide, which is 1 to 36 PTHRP. Although that one claimed biochemically actually has been proven, but it claimed has a similar affinity for RG state of PTH type 1 receptor. RG state is actually GTP gamma S sensitive state. There are two states in which this PTH1 at the G protein coupled receptor exists. One is that GTP gamma S sensitive, and the other is R0, which is GTP gamma S insensitive. So what happens is that teriparatide has a 4 to 5-fold higher affinity for that GTP gamma S insensitive type than PTHRP. And that is the reason, biochemical data wise, PTHRP's cyclic AMP stimulation was less prolonged than PTH's cyclic AMP stimulation. And why the cyclic AMP stimulation, the amplitude is important, is because more vigorous is your cyclic AMP amplitude, more likelihood of getting rank ligand stimulation high.
Yes.
So all those things have been proven biochemically very nicely. But when we saw the abaloparatide clinical trial data, well, the anabolic window was also lost the same time when teriparatide was lost. So that is what I'm saying is that
Yeah.
even though it is a second generation, quote unquote, second generation anabolic therapy, it doesn't really has any significant increase over improvement over type for over teriparatide. Do you agree with this?
Yeah, it's very interesting, the mechanism. No, you just put it across at the level. Yes, and one like I am fascinated by your comment because we will be interested in seeing because this anabolic window is maintained. And Dr. Vaidya had asked about what happens in 6 months. So that also we'll get back to you because we will see how the magnitude was how no like the magnitude of that window. We'll get back to you.
Is your center planning to have PT QCT, or you of course have QCT? Do you plan to include those strength analysis using FEA kind of thing?
Finite element.
Expand
Finite
to that.
element.
Finite element.
Finite element.
See,
So that you
actually,
can do the stress strain kind of thing and fracture prediction, although those are predictions.
yeah. See, we have for a QCT we are planning QCT, not in next 1 year or 2 years, maybe by 2024 or 25. We have a plan to do that. But other than that, we have to really work on. But we can collaborate with, we get a, our concepts will be clear when we interact with you. Because it is at the side, very, very important for us to know the basic concept also.
In this regard, I will tell you what has happened is that we at CDRI were doing, or we still keep on doing, screening of FDA approved drug libraries. We are doing it for last now 11 years.
Okay.
And it is a blind screening, in vitro screening, osteogenic screening, and from there we move on, whatever are the FDA approved drug libraries. And there we bumped into a group of phosphodiesterase inhibitors. And you wouldn't believe that out of that screening, 70% turned out to be osteogenic.
Okay.
And the best one so far in our hand, which we have shown in 3 species, in rat, mice, and rabbit, which is pentoxifylline.
Oh.
1/6 the human dose, 1/6 the human dose of pentoxifylline oral in rat, mice, and rabbit had effect absolutely comparable to teriparatide.
Oh my goodness.
Absolutely comparable to teriparatide. And it also showed the same features of teriparatide. For example, with time, the resorption going up, but the surface referent bone formation markers were mineralizing surface by bone surface or bone formation rate were absolutely comparable to teriparatide. And so now AIIMS New Delhi is doing the first round of clinical trial. Dr. Bhabu Garg is doing the clinical trial for DHR funding to compare pentoxifylline and teriparatide in post. I think from March this year he has started.
Oh,
so,
very, very okay.
Right.
So what is the mechanism? What is the mechanism of pentoxifylline?
Yeah, the mechanism, as I said, it is a pan-phosphodiesterase inhibitor. That means it inhibits all 11 phosphodiesterases. Now, the osteoblasts express PD4 and PD5. Now, when you suppress any PDE except for 5, all other PDEs will tend to suppress PDEs in such a way that cyclic AMP will go up. So we can share with you our papers in bone and Calcified Tissue International, I will share with you. You will see where we have shown the cyclic AMP kinetics comparison between pentoxifylline and teriparatide. It actually superimposed in osteoblast, superimposed. So that kind of a blip on cyclic AMP, because the cyclic AMP level has to momentarily go up. If it goes up for longer duration, it will kill the cells. If it, yeah, so the kinetics is very important. So when we screened all the phosphodiesterase inhibitors in the cyclic AMP and cyclic GMP assay and compared it with PTH in vitro, detoxifying and sildenafil was comparable in terms of GMP, cyclic GMP activation. So that is the reason we have shown that we found that sildenafil also is a bone anabolic.
Oh,
Yeah, bone
very
anabolic.
well.
Yeah.
Okay.
So what I will the message I am trying to give is that let us see what is the outcome of the trial, what Bhabuk Garg is doing, and if it comes out to be promising, we may think about doing a multicentric. He is doing a phase 2. Then we will contact you as well as other centers through ISBMR, and then we can think about giving a multicentric attempt so that we can have an oral anabolic,
Very
oral anabolic, and that would be the best thing to do, I thought, in Indian setting.
fantastic. Fantastic. Congratulations.
Any other questions? Sorry, I was only talking. Any other question, please? Dr. Vaidya's hand is raised. You want to ask?
No. I think I should have.
Okay.
I had good answers from all of you, and it's always pleasure to listen to you when you create discussion, Dr. Naividya. It's really, and thank you so much, Dr. Thomas. Your answer to that will be very interesting to see the course that is that you could find out amongst 40 and odd women, and if you have the courses that has happened, like for example this, as they say, that anabolic markers of anabolic response are still persisting at 2 years, whether it is uniform and what is the the range, how many persist with that.
That's right. That's right.
And did you feel a little tempted to continue in some?
I think that not happened before, after last week's meeting with our ISBMR group, because when there is a persistence of window, whether we should continue, that is not the initial thought. That is after discussing with Dr. Badeda last week, last Saturday, we were wondering whether we should extend it.
Yeah, it would be interesting to generate that data. Could be helpful. And one more question that later on you could answer that how many required additional in between?
Additional what in between? Which parameter?
No, additional parameter, no, additional therapy besides.
In this group, no one. In this group, no way, no.
Okay.
You know, Sanjay Badada is also alluding to the possibility of using weekly teriparatide.
Yeah.
Sorry.
Yeah, I'll not put it across. We are also trying to use in selected patients 60 microgram subcutaneously once a week.
And another thing, would you be facing any regulatory issues if you go beyond 2 years with daily PTH?
Yeah, that we have to conduct as a trial. As if only one in glucocorticoid induced, there is only one trial which has showed 3 years. I fully agree with you that we won't be able to do straightforward. We have to inform the regulatory authorities and we have to get the permission. I fully agree with you.
Right. Although, you know, it is an irony that FDA has still not removed the black box warning for teriparatide,
Right.
while more than 10 years there is not a single case of osteosarcoma.
Yeah,
I know, by now they should have removed it. You know?
Correct.
Yeah.
Thank you.
Okay.
Thank you
So,
so much.
Thanks.
congratulations, Kripa, for doing such a marvelous work. And you also is a fluent speaker, and I'm sure you are also a very sought after teacher. So I can see the full potential of a mentor, which is very
Thank you,
much
sir.
missing in our academia.
Thank you, sir.
Okay, and so your center would be now copied for every coming this webinar. We have one
Thank you, sir.
coming up on which is today is 9th, coming up on 22nd August. Sorry, July, and you will get email notifications.
Thank
If
you,
have
sir.
time, please join. Okay.
Thank you, sir.
Thank you so much, and thank you so much, Dr. Thomas Paul. I appreciate
Thank you, sir.
it.
Thank you so
Thank you
much.
so much. And goodbye to everybody. Bye. And oh, by the way, okay, sorry. I just got